Welcome to Point Blank. Tonight's episode is sure to put you all to a good night's sleep.
Right, we'll see. Okay, but... Right, let's see. What should we first talk about?
We'll be exploring some of the more popular treatment methods for insomnia. With us in studio this evening is Dr. Lim Li Ling, who was actually on the committee that put out the MOH sleeping pill prescription guidelines published in September this year. Yeah. And Helmi, who is a self-professed insomniac.
Now let's take a look at the sleeping situation first before we actually delve into the topic. Get no sleep? And is that sleeplessness affecting you in the day or even worse when you're at work? Well, you may be suffering from insomnia. About 1 in 10 Singaporeans are tossing and turning in their beds or staring at ceilings for hours throughout their nights. This is a serious problem that can lead to unhealthy or even deadly consequences. And one common treatment option for many sleepless Singaporeans out there is the popping of sleeping pills. But unknown to many, the hidden dangers of over-relying on these potentially addictive pills can result in a range of withdrawal symptoms such as trembling, hallucination, paranoia, and epileptic fits. Rebound insomnia can also occur if the patient stops medication, which basically means you lose sleep again once you stop popping those pills. In Singapore, the prescription of large amounts of certain sedatives like benzodiazepines has been a major concern of late. One key reason, the sleeping pill addict and those dependent on the drug could very well become abusers of the drug. The most commonly dispensed benzodiazepines are Domicum and Aramine. In the first half of 2006, 25% of the abusers arrested abused nimotazepam, while 6% were arrested in the same period in 2007 and 5% in the same period in 2008. Well, it certainly seems like good news as the figures are indeed going down. But the Health Ministry is not resting on its laurels. They updated its prescription guidelines in September this year for benzodiazepines. For instance, doctors must now keep detailed records and indicate the dosage, duration of use, and reasons for prescribing these sleeping pills if there are any physical signs of illicit use. They must also alert the Health Ministry and the Central Narcotics Bureau if they suspect a patient is abusing the use of sleeping pills. Although these guidelines have been in existence since 2002, the updated version now requires doctors to refrain from giving out highly addictive pills such as Domicum and Aramine. Some doctors in our public hospitals have also said that they are indeed seeing more patients being referred to them by general practitioners ever since the revised guidelines were published. But these guidelines do not rule out the fact that doctors still have considerable freedom in exercising self-discretion when ascertaining the health risk of prescribing sleeping pills to their patients who may or may not be bordering on addiction. The guideline statement of intent states that each physician is ultimately responsible for the management of his or her own unique patient in the light of the clinical data presented by the patient and the diagnostic and treatment options available. So are these guidelines sufficient? Should they be tightened further? Should medication be considered a last rather than a first resort for distressing insomniacs out there? And if so, what are some of the alternative remedies or medicine available for the treatment of insomnia?
Okay, so we're going to ask the
Dr.
good
Lim.
doctor here.
Right.
Okay, what's the general state of insomniacs in Singapore?
Well, I think that the prevalence of insomnia locally, we don't have formal statistics, probably approximates that worldwide. So anything from 10 to 30% of Singaporeans probably suffer from insomnia. The more severe insomniacs, which require seeing a physician and getting medication, probably around 10%. And this is the tip of the iceberg, the number of patients that we're seeing. I think recently, with a lot of stress in society, with the financial crisis and retrenchment or imminent, financial crisis for each individual, we're beginning to see more of these problems. But as a whole, I think Singapore generally is a rather stressful society. So we definitely have no shortage of patients in our sleep disorders clinic who suffer from insomnia.
Yeah. Okay. So Helmi, you are suffering from sleep, like insomnia and all that.
Yeah, I've been suffering from insomnia for more than 10 years now. I think it started when I was 18, when I went to national service. I had to sleep in a double-decker bed. And I slept in the upper deck, and my bunkmate slept below me, and he was a very bad sleeper. He kept tossing and turning. So for 6 months of BMT, I slept very badly. And then after that, I went to university, and then I had a habit of staying up late to study or to read or even listen to music and try to decipher the lyrics. So that went on. And then when I took up a job at SPH, it was also quite stressful.
Yeah, it got even worse, right?
It got worse. It's true. Because, you know, as reporters, you worry about deadlines. You're always like, okay, something happens, which means the reporter has to quickly get the story or follow-up story, and it has to be published the next day or the day after that, because anything more than 2 or 3 days would be stale. So we always had to like meet deadlines. So it was, my first year was horrendous. Like I went without sleep I could go without sleep for 2 to 3 days because I was so worried about my stories and my deadlines. When I went out for lunches with my colleagues, I would talk rubbish.
Oh yeah, were you delirious?
Yeah, I was like sometimes delirious, and I sometimes would finally get to sleep over the weekend. That was when I crashed and slept for about 15 hours straight. But during weekdays, it was pretty bad. Yeah. I tried to get help from doctors. I tried to get medication, sleeping pills, but no doctor would entertain me for more than 2 visits. They would at first give me sleeping pills, and then after 2 visits, they said, okay, that's enough. You have to get off it. These things are not meant to be permanent solutions, and therefore, you know...
So, okay, they gave you how many again? 2 weeks supply or...
No, as in, like about a week supply.
Okay.
And then if I went for a second visit, they would still help me, but by the 3rd visit, they would say, no, this is, you know, you could get addicted to it and blah, blah, blah. And it was so bad. I tried everything from exercise to buying those tapes with the sounds of oceans, to buying better pillows, to, like, every time Time magazine publishes its annual Why Are Americans Sleeping Less or whatever it is, I would, like, quickly buy it to try and find solutions, and none of it worked.
Okay, wait, sorry. What do you say to that? Is that quite a common case?
Actually, this is a good kind of a textbook case where people start with having a normal sleep pattern, and then usually something precipitates the bad sleep pattern. Usually it's a stressful event or an event during which their sleep pattern gets disrupted. So you start that whole cycle of tossing and turning and not getting good quality sleep. Then you start to develop this anxiety specifically towards sleep, for example. Then that anxiety itself creates a vicious cycle which makes you have anxiety, and then you can't sleep because of your high arousal state. Now, in the long term, if you have insomnia, you actually have an increased risk of developing depression. So it may start off with like your BMT bunkmate being very noisy, and then it led on to your job being stressful. But then you develop this poor sleep habit, which was perpetuated by your poor, your lifestyle choices. Your job necessitated that you meet deadlines and things like that.
Yeah.
So even if that deadline were over, or you left that job, or you left BMT, then you may ask, but that thing is over, how come I still cannot sleep? And it's because you have developed either a secondary depression or you've developed a very strong aversion and anxiety towards sleep. So the treatment for it actually, if you had developed secondary depression, would be the treatment of the depression, or if you've developed a secondary anxiety disorder, would be to treat the anxiety. So a lot of the treatments of insomnia correctly should be based on behavioral changes. So if you had been a patient, early on in the early days of your stress, then what probably would have been good would have been to give you some instruction on what you were doing that was perpetuating this insomnia. And early on, we probably could have tried to nip it in the bud. But after a long period of time, maybe you required strong sleeping pills for a short term and maybe some antidepressants. So the treatment varies depending on the cause and what's happened. But what you've just described is fairly typical. A precipitating event, like something stressful or something which disrupted your sleep, then followed by the development of a maladaptive, sleeping pattern, tossing and turning, doing all kinds of things to get yourself well, but because it wasn't the right thing, it didn't work. And then if you develop a secondary depression or anxiety, then that becomes another thing altogether.
All right, now Helmi was mentioning something about difficulty in obtaining these pills from doctors after several visits to the same doctor. In relation to the video that we just saw about prescription guidelines, etc., do you think that with the new guidelines being revised and published right now, would it be more difficult for genuine cases of insomniacs to actually go out there and get proper treatment and proper cure? Now?
I think in general, the treatment of insomnia at the moment is not optimal because the learning that we have, the knowledge that we have about insomnia and how it's treated is fairly new. So now we know that insomnia is just a symptom. It doesn't mean insomnia is a diagnosis. Insomnia means sleeping pills. Insomnia can be due to depression or anxiety. It can be due to life stresses. It can be due to medical conditions, and it can be due to primary sleep disorders like restless leg syndrome, for example, where a condition whereby your legs are very uncomfortable. So once you have the correct diagnosis, the correct treatment actually is not sleeping pills per se, but it's a treatment of whatever the underlying condition is.
Right.
And I think the limiting factor for most patients getting the correct treatment early on is that, unfortunately, in medical schools, when we were in medical school, before all this knowledge came about, it wasn't well taught. There's not a module that teaches us, for sleep disorders, think of these 10 things, check it off, and then go down the correct algorithm.
Like the restless legs disorder thing. I mean, this is probably the first time that I'm hearing about it.
Yeah.
So could it be like all these like symptoms that people are just not identifiable with? Like, let's say if I have restless leg syndrome, I wouldn't know it.
Yes.
And my doctor probably wouldn't know it either, is it?
Yes. That's partly because it's not widely taught in medical schools. In America, which actually probably leads the world in sleep medicine, they do have a kind of a push to teach this in medical schools. But because it ranks, by tradition below, mainstream subspecialties like cardiology and, lung diseases, diabetes and obesity. All these are major important conditions. But locally, we haven't caught up in terms of the amount of teaching that is required. So I think the limiting factor is disseminating this knowledge.
Okay.
So professional societies like the Singapore Sleep Society, we do try to have a lot of teaching forums so that doctors can learn, like if a patient like Helmi comes, what do we need to make sure that he has or he does not have. And then in his case, whatever the diagnosis, I think he told me what it was, that he was eventually given something which works well for anxiety. Right?
I was eventually asked to see a shrink, and I was not very happy about that because
no, but
it was very expensive.
There's nothing wrong with seeing a shrink.
I thought there's nothing wrong with me,
Yeah.
but it did me a lot of good because he put me on some kind of medication. It's not exactly a sleeping pill, but it helps you reduce anxiety when you're just about to go to sleep.
Okay.
And I've been on that for about 7 or 8 years now.
Yep.
And I'm perfectly fine now. And
well, you're actually a very good textbook example. Most of the patients that I see with insomnia, in the end, only a very small percentage of them require sleeping pills, usually in the beginning.
Yeah.
And a lot of them do well with a range of alternative treatments which are non-addictive. For example, anxiety-reducing medications, antidepressants, treatments for restless leg syndrome, for example. And all of them actually require a behavioral, what we call, sometimes we call it cognitive behavioral therapy, and it's a formal program where we teach patients to relax naturally and change lifestyle habits that are not conducive to good sleep. And that's actually the mainstay of treatment. And a lot of research has been done on this in Western populations, and it's shown that the most common forms of insomnia actually respond best in the long term to what we call cognitive behavioral therapy, which is educating the patient on what they're doing that's not right, and teaching them natural relaxation techniques, and just telling them specifically what are the things that are making them sleep poorly.
Yeah.
Right.
So I think a lot of things are indicators that you already know. Okay, but before we go further into that, we actually have a web comment from this person called Gorgeous Guy. You can see it from the back of you. Hi, Doc. I'm either a real light sleeper or I don't sleep at all. I just lie in bed. I have a normal life, not too stressed at work, but still I have problems. So how? So what? So if somebody comes up to you and says this, like, so how? It's not like stress, or...
Or at least they think it's not stress related.
Okay, well, non-surprisingly, I get lots of questions like that in my email. A lot of people email me to ask me questions like that. Now, usually with a one line like that, it's very difficult. A lot of people are actually unaware that they have anxiety or depression or stress. So a classic example, maybe somebody just like this writer who's written in, I mean, I have patients who tell me, no, everything is fine. The usual, everything is fine kind of comment. Then after talking to them for a period of time, usually first consultation, maybe 30 to 45 minutes, we'll talk to them and we get a better sense of what they're doing. Usually it's either something they're doing wrong in their lifestyle or they actually have, well, subconscious hidden sources of stress that they don't recognize themselves as being immediately the cause of their insomnia. So the first step for somebody like that is probably for us to talk to them and to determine what are the lifestyle factors that are contributing to this.
What if this guy just does nothing, like just very chill and all that? But it's probably because he does nothing that could be a stress factor, maybe.
Actually, I want to touch on something that you mentioned about behavioral cognitive
behavioral therapy. Yes.
Therapy to, you know, I in the early stages of insomnia, quite a lot of doctors recommended that to me, but I found that it was not easy to carry out some of the things that they asked me to do.
It's interesting that you mentioned. Are you asking me about its effectiveness?
Yeah, I found it rather ineffective.
Okay, is it because Singaporeans in general are a skeptic bunch?
No.
Or cynical? No, I'm just wondering.
What were some of the things that they asked you to do?
What did they ask you to do?
Like relax, do yoga, meditate. You know, all these things I found impossible to do. I'd be like trying to meditate and get really bored. Like, how does this help me? And you know, and listen to relaxing music or classical music, which I do not like. So none of those things ever worked. And and then like I was advised to switch off TV an hour before I wanted to go to sleep, or read a book. But then I found myself very engrossed in the book and kept reading it the whole night. So, and it just did not work. And when push came to shove, it was medication that really worked. I mean, for me.
Again, you're actually quite textbook in your experience. The cognitive behavioral therapy is well proven to be effective in Western populations. And that could be a function of the way maybe Western patients are different in their mental makeup and their receptivity to a treatment that's behavioral. That means you have to do something, you have to practice, you have to come for weekly sessions of an hour each for about 4 to 8 weeks. So this requires perseverance, it requires you to practice it. Now in this kind of society like Singapore, it is our experience at our sleep disorders clinics that patients actually have a high rate of default, and commonly their experience is what you have reported, that it's not effective. Then they'll say, doctor, I don't really want to go back to it. We are rather disappointed that our experience does not parallel the Western experience. And actually, it is indicated for us now to conduct a study to see as to why this happens. Is it something about Asian patients that are different? Is it just the mentality is different? My personal impression is that I think our local population prefers the doctor to give you something, to do something to you, that fixes you. Not you do it yourself. You know, if I could do it myself, I wouldn't come to you. Sometimes they have that. So I think it's also maybe the cultural mindset that it's more like, come, do something to me, give something to me, and let me get better. So maybe that one is not something that we can overcome. But we haven't had the opportunity to study in detail, partly because we have so few patients. And the limiting factor to cognitive behavioral therapy is that a lot of our patients, the majority don't speak English, or they speak dialects, and a lot of our psychologists, and the few psychologists we have who are trained to do this,
all speak English.
May only speak English, and so there's a language barrier also, because you need to teach concepts of what it means to be, why you can't sleep, why is your arousal state high. This is because the whole thing is cognitive. Cognitive is the intellectual part. You cannot sleep because your lifestyle is such. You are doing things which are not conducive to sleep. Therefore, you have to change it. Then you have to practice all of these things. So it's a kind of a long drawn out exercise which requires understanding, and it's quite complicated concepts. So if I had to do it and translate to Hokkien, for example, which is not my strong point, I think a lot will get lost in the translation. Even someone like me who sees a lot of patients. So I do what I can, but I think something is lost in translation. So you're correct to say that at the moment, I find it most effective in patients who can speak the language of the psychologist who does it. And the other limiting factor is that not many psychologists are specifically well-trained in cognitive behavioral therapy for insomnia. They are well-trained for, managing stress, depression, anxiety, but this specific form of cognitive behavioral therapy actually requires specific training, and I don't think there are more than a handful of such specialists in Singapore, and not all of them speak well in dialects and the languages which most of the patients are comfortable with.
Okay, we're going to take a short nap. When we come back, more treatments and more discussion.